I think my last question is going to be really regarding access. Since both of us working at Emory, a larger academic institution, we have access to PSMA PET scans. We have access to these de-escalation trials. We have multi-D, discussions, on a weekly basis. If you have, let's say a viewer that's watching that lives in a more, or works in a more rural setting, a more community-based practice, they really don't have the imaging, the imaging as well as the communication with outside providers. What do you think we can do better to help bridge the gaps to treat our patients?
Yeah, I think, I've from all the patients that I've seen who've been referred by community oncologists or urologists, I've oftentimes see, that they are doing a great job at trying to reduce the burden of treatments as much as possible. So, oftentimes patients will be incorporating intermittent ADT as a reasonable strategy for metastatic disease, even. However, I think, there are some challenges as well. Specifically, I would say that in terms of the systemic therapy itself, we know that patients on doublets will do better than single agent. And for those patients, I think if you were trying to de-escalate or try to improve toxicity profiles, I think shorter doses of Lupron can sometimes be helpful, the 1 month or the 3 month dose instead of the 6 month dose. I think switching sometimes to relugolix can be very beneficial as well as a de-escal, in terms of from a toxicity perspective, just because that has a better toxicity profile, especially in elder and frail people. You could use that over some of the other medicines that we have. And then, I think incorporating radiation therapy early on with MDT, if you have access to a radiation oncologist, is going to be very crucial as well as a de-escalation strategy in the community. Yeah, those I think are some of the biggest things. Yeah.
Yeah, and I think you really highlighted the key points. And one thing that you did mention is that there is still, it's not a large cohort of patients, but I think last time I looked at the data, around 20% that are still receiving only single agent ADT, monotherapy, which we now know is inferior care and, should only be used for maybe more frail patients that can't tolerate doublet therapy if they do truly have metastatic HSPC. So definitely just getting the word out there that there should be at least on a doublet therapy per our guidelines. Of course, there are patients that can't handle doublet, maybe they're too frail, could consider androgen deprivation therapy, and then really keeping open communication, with our community providers, just understanding some of these barriers to try to help bridge the gap and really get our patients to superior care.
Absolutely. And I think for some of those patients where you are worried about escalating treatments, you can just kind of start them on short-term ADT and then see how they do. And then maybe add, the appropriate hormonal intensification at the right time. And you can play around with the doses to kind of find the right dose for the patients, but they can still have benefit even at the lower doses.
Yeah, I agree. There's no harm at, starting slow and seeing how the patient does. So I
Absolutely.
completely agree with you. So to wrap up, I want to sincerely thank you, Dr. Ahmed, for taking the time to join us on GU Oncology Now. And I guess, to close up, do you have any final words, any final recommendations or summaries from our talk today?
Yeah, I think, in summary, I would say that, we have a lot of treatment options for patients. However, it is important to kind of think about de-escalating treatments to provide better quality of life. When we're prolonging people's lives, we also want to be thinking about their quality of life. And I think in prostate cancer, in the large majority of patients, you're playing the long game. And so essentially, there are reasons to de-escalate or even come off of treatments completely, and you could safely monitor their disease over time, and then reintroduce treatments at the right time. But yes, we are waiting for trial data to come out to kind of consolidate this. And I think just with how trial data came out with intermittent ADT, once we have data for trial data for intermittent hormonal intensification, then I think that could also become more widespread. And then
Yeah.
finally, I think using MDT is crucial, especially when you have oligometastatic disease, and its role is being studied in high volume metastatic disease as well.